Okay, good afternoon, everybody. My name's Simon. I'm the brand manager for Lumenis, covering the EMEA region in the UK, based in the UK. I'd like to introduce to everybody Dr. Bazinis. Dr. Bazinis is an ophthalmic surgeon. He has a speciality in glaucoma treatment and anterior segment surgery. He's from Athens and studied at the Medical School of Patras University, and he's done postgraduate studies at the Medical School of Athens University. Dr. Bazinis also holds an MSc in molecular medicine and completed a PhD studying the development of the visual system. He's completed his training in ophthalmology at the largest hospital in Greece, and he became a fellow of the European Board of Ophthalmology. He's since moved to the UK, and he's worked with Professor Bloom and his team at the Hillingdon Hospital's NHS Foundation Trust, and also the Western Eye Hospital and Imperial College in London. This is where he's gained significant experience in dealing with all types of glaucoma and complex cataract surgery. He currently has his own private practice in Athens. He's also the glaucoma lead at the oldest private ophthalmic hospital in Greece. So with that, I will hand over to Dr. Bazinis for this afternoon's webinar. Thanks very much.
All right. Thank you very much, Simon, for that lovely introduction. So today we're going to discuss about the Lumenis Selecta Duet and how you can use that to treat conditions like glaucoma with SLT, as well as the use of the new Smart V to treat floaters. So this is the launch for this is the new platform for the Duet. So it's actually one platform for SLT, YAG treatment and floaters. It has a new 12-inch panel PC, a new user interface, and of course the new illumination is with LED. Talking about SLT, it's not something really new. Selective laser trabeculoplasty was first introduced by Mark Latina in '95, and it was approved by FDA in 2001. So what it actually does is that it stimulates the drainage channels inside the eye and makes them work better. How exactly it works? Well, no one really knows, but it does work. So it stimulates the drainage channels inside the eye, it makes them work better, so the pressure goes down. Oldest paper from '84, when ALT was mainly used, has proposed three mechanisms for the action of trabeculoplasty. First of all, there is a mechanical effect with some shrinkage of the anterior meshwork. There is a cellular effect, and of course, there is a biochemical effect causing the alteration in both the rate of the composition of the extracellular matrix. Okay. This is an old study from '94. It's actually from the predecessor of my mentor, from Clive Migdal, where they were testing whether a trabeculoplasty can replace the use of drops. So here you can see that in 4 years post-operative time, actually laser and medicine were equally effective in lowering the IOP, and this is something from '94. We all know that SLT is quite different than ALT. So what SLT does is a selective thermolysis, whereas SLT, you can see here from the picture of the electron microscope that it's like creating a hole in the meshwork. So it creates an opening to the meshwork to make it drain more. The only thing you need to know to perform SLT is actually know how to distinguish the structures inside the angle of the eye. So you need to be able to differentiate between the ciliary body band and the scleral sphere, and between the pigmented trabecular meshwork and the non-pigmented trabecular meshwork. It's quite different and more easy than doing ALT. You can see that in this picture, you can actually see that SLT, whereas it is selective, the spot is much larger than ALT. And what you actually need to do is cover the whole trabecular meshwork with the aiming beam. It's not something. SLT is something that's well studied. And in most of the studies, the machine that it was used is the one by Lumenis, because this was the first machine ever to be developed for SLT. And it has been proven a lot of years ago that SLT is as effective as ALT, and it's not as destructive as ALT. This is why you can repeat SLT, but you cannot repeat ALT treatment. So in 5 years follow-up, there is a similar reduction in the drop of in pressure, and SLT you can repeat that, but you cannot repeat ALT. So the new study that has come out in 2018 by Gus Guzzer and his team at Moorfields, it shows that SLT can be a first-line treatment for glaucoma. So what it did, it compared SLT with drops in patients with open-angle glaucoma or ocular hypertension who were untreated, and the only surgery that they had was cataract surgery. So what they found was that 74% of the patients undergoing SLT were drop-free in 3 years follow-up. So this is a very important measure, and this is actually a very important percentage for people that are newly diagnosed with glaucoma. And another thing that they did say, and they did mention quite recently, is that the 2-month drop in pressure is predictive of the success rate of the SLT. So this is from the EGS guidelines in 2014. You can see that the first line of treatment is mentioned as being always a drop. So you can either use a prostaglandin or a beta blocker. So a lot of previous studies have shown that medical therapy, SLT, is as equal and sometimes better than primary medical therapy for the reduction of pressure in newly diagnosed glaucoma patients. So this is a study from 2006. This is another study from 2009 showing that SLT is actually as equal as latanoprost in the reduction of pressure in a 6-month follow-up. And even in 1 year follow-up, you can see that a 360-degree SLT treatment can have a reduction in the pressure equally successful as latanoprost. And it's not as difficult to perform, as I said, and it's less operator dependent because the spot is bigger. We're talking about a 400 micron spot, whereas in ALT we were talking about a 50 micron spot, and you don't have to be so specific in the targeting of the meshwork. You just need to cover the whole meshwork. I will come back to that later on when I will discuss how you do SLTs. And it also works in many types of glaucoma. In shoot exfoliation, for example, which is very common, at least in Greece and in Nordic countries. Even in normal tension glaucoma, even in NTG, you can see a drop reduction equal enough to guarantee stability in the progression. It is as equally effective in faking and pseudo-fake patients. So in both groups, in this study, you can see that the pressure, there was a reduction in pressure equally. So it was equally effective in both faking and pseudo-fake patients. And it is, as I mentioned before, it's a repeatable treatment. So you can see that actually the second time you perform SLT is as equal as the first time. I think the inventor of SLT has mentioned that he has done patients even 5 times, five repeat treatments of SLT without any issue at all. The other big question about SLT is how much you want to treat. So do you need to treat 90 degrees, 180 degrees, or the whole 360 degrees? So definitely you will not treat 90 degrees. It's better to treat 180 degrees. And I do believe that it's better to treat 360 degrees. So treating the whole eyes is much more efficient and helpful than treating 180 degrees. Even though many studies have not showed a significant change between 180 and 360 degrees. I must mention that in the light study, that's one of the biggest studies for SLT. The protocol that was used was 360 degrees treatment and 100 shots in total. So I think it's better to use 360 degrees than using 180 degrees for treatment. So as I said, previous studies have not shown that there is a difference between 180 degrees and 360 degrees. Probably the 360 degree treatment lasts longer than the 180 degree treatment. And talking about side effects or adverse effects, you have to be careful doing SLT in pigment dispersion syndrome. So in heavily pigmented angles, there is a chance of doing the opposite that you want to do. So there might be a long-term pressuring spikes, which may require surgery. It has been mentioned before. So you have to be extra careful with pigment dispersion. And I haven't seen that ever, but there have been reports of corneal haze or uveitis after laser, after SLT in people that were positive for HSV antibodies. So this is the treatment protocol. This is what you need to do. This is what I do. This is pretty much what was being done in the light study. So before the treatment, I use a drop of pilocarpine 2% and a drop of apraclonidine 0.5%. I use the Latin agonia lens to visualize the angle. I do a 360 degrees of treatment in total, doing 90 to 100 shots. I always start with an energy of 0.7 millijoules and fine-tune the energy according to the microbubbles from the first shots. You should never treat twice a specific area. And I do check the pressure after 15 minutes of treatment. You may see some cells in the AC after the treatment, and you need to check the pressure, just make sure there is no spike afterwards. You have to be careful in PDS, in pigment dispersion syndrome, as I said, and pseudoexfoliation glaucoma. It requires a little bit more experience and a little bit more cautious treatment. And it has been mentioned, and this is something that the patient should know, that if they are using a prostaglandin analog for their glaucoma, it is possible that the treatment will be less effective. And after the whole procedure, there are a lot of options for post-operative treatment. I normally don't give any additional drops for that unless they are in pain. So if they're feeling slightly uncomfortable, which is relatively uncommon, I use a non-steroid anti-inflammatory drop for about 2 to 3 days, twice a day. I use bromfenac specifically. There is a study mentioning that if you use a combination of steroid drops and NSA drops, you will get a better reduction in the pressure. Well, I haven't applied that to my everyday practice, so it is possible, but it was only a 3-month follow-up from the study. So I don't know if in the long term you will see any difference between that or giving nothing at all. And I have to say that there are a lot of new things trying to introduce something new in trabeculoplasty. There is that micropulse laser trabeculoplasty, which is not a new concept. It's something used back in the 90s, where you don't treat the whole trabecular meshwork, the 360 degrees. You don't get an endpoint, but you get a reduction in the pressure. But there are no studies until now that they have so long follow-up as SLT. So I don't know about the efficacy of the treatment in the long term. So these are the laser parameters comparing argon laser trabeculoplasty, Selecta laser trabeculoplasty, and micropulse laser trabeculoplasty. What you can see is that the energy used with SLT is way lower than any of the treatment. So you do get an endpoint with SLT, and by endpoint I mean you do get a cavitational bubbles, so they can guide you through the treatment. In ALT you get that blanching of the pigmented trabecular meshwork. There's no visible reaction in micropulse laser trabeculoplasty, and this is something that you can repeat safely without any adverse effects. And if you can see in total, as I said, it's the less energy is only used in the in the SLT. So the less energy used in the eye is only with SLT, even with micropause, and even with a 15% duty cycle, you can see that you may need a 2-watt power for every shot. So the other thing you should consider is that what SLT does, it treats the cause of glaucoma in general. So what we do have is an increase of resistance at the juxtacanalicular trabecular meshwork, and the only treatment until now that tries to address the issue is SLT. So probably pilocarpine or bimatopros are the ones that do increase the conventional outflow, but SLT is the one that targets the trabecular meshwork. So this is in general what we have what we have for the treatment of glaucoma. This is a slide that I do normally start with every presentation I do in conferences. So for laser, I always say that it's quick and simple, that it's only short-term effect. Well, and by short-term, we do know that you can have a 74%. There's a 74% chance that in 3 years, a newly diagnosed glaucoma patient will not need a drop to control his glaucoma. So this is my algorithm this was my algorithm for the treatment of glaucoma. This is how things have evolved, and I do believe that eventually, and this is what I'm doing now, this is how things are considered for treating glaucoma. So I do have laser trabeculoplasty as the first option, first line treatment. It has replaced my the drops or a PGA or a timolol. And so this is one aspect of the treatment that you can have with the Selecta Duet. And the other aspect and the new thing that you can do is treat the floaters, which is a new, very interesting area. So everyone knows that floaters disturb vision, and they do project shadows in the retina. Here you can see in the photos how this is done. And not all floaters are equal. We don't treat every floater that we see. So it's a different thing if you have an asteroid hyalosis, which is a senile degeneration of the vitreous. It's a different thing you have a vice ring, which is quite disturbing for most people. It's a different thing that floaters are cloudy, vitreous fans, and of course you have the floater duet, which is a vice ring along with a degeneration of the anterior vitreous body. So vice ring is the most disturbing one. It's very common. It's large. It is visible. Everyone that does have a vice ring will always say that I do see it. And especially in my practice, where I come from a very sunny country, and we do have sun about 250 days a year. So a lot of people, even in the winter, complain of for floaters. So it is something that you can treat, and it's usually far away from the retina or the lens. So it's in the safest area that can be treated. And as I said, it's very, very, very disturbing. So up till now, I think the main thing that we all said to our patients is that, well, you don't need to bother about your floaters. You have to learn to live with it. But floaterectomy was something that in the past 10 years was really introduced, and really the VR surgeons were promoting very well. And well, enzymatic vitreolysis was something that was used in the last, I think, 5 to 6 years, but now it's off the market, at least in Greece. And the new option is actually to do a YAG vitreolysis, to use the YAG laser that you have, to use a Duet to destroy, to completely vaporize the floater. Up till now in the market, there are two machines. There's the Lumenis one with a smart fee, and there's the LX Tango Reflex. These are the two main machines that are used, that are designed to treat the vitreous body and treat floaters. And the whole way that the two machines work is very, very different. So in the LX, what you have is you have a coaxial illumination or a trans-illumination of the vitreous body, like you do with a slit lamp, and there's a mirror. And when you push the button to fire the laser, the mirror drops down. So for a fraction of the second, you're not able to see what's happening. So you do lose the view slightly, and you do have that very, very red reflex that you do get like you do when the slit lamp. The different thing and the different design with the Lumenis one, the Smart V, is that you have two different prisms that they get a focal point inside the vitreous, not in the macula, not in the posterior part of the eye, but inside the vitreous. So you do get a better reflection. It's not as red as the red reflex that you get from your slit lamp, but it's not something that you do need. You don't need a red reflex like you get in the slit lamp. You need a good visualization of the vitreous, so you need to be able to see where you're aiming the laser. So you get a lot less reflection and better view of the vitreous. Here in the left picture, you can see how you see the posterior capsule with off-axis illumination, and in the second one, you can see with on-axis. So you do get that good visualization of the vitreous without getting that very, very red reflex that you don't need either way. So this is the oldest one, the oldest add-on for the laser. So you can see with the new Smart V, you get a double prism, one in the bottom and one in the top. And you can see with the old prism, in the coaxial illumination, in the on-axis one, the laser beam was blocked, so you cannot use the on-axis illumination. With the new one, with the Smart V, this is a very good benefit. So you do get, as I said, you have a dual prism, a superior one and an inferior one, and you get a focal point inside the vitreous, so inside the area you want to treat. So this doesn't interfere with the laser beam, and you get a very good visualization of the whole vitreous body. But apart from using that in the for dealing with floaters, for treating floaters, another way that another good uses of the Smart V is in iridotomies. So in iridotomies, I used to do iridotomies with off-axis illumination, but I find it very, very easier to do it with on-axis, because you can get a good visualization of the crypt of the iris. You can see the point of the iris that is thinner, and with less shots you can get a very good iridotomy. So here you can see what I'm saying, that in the off-axis illumination, the visualization of the iris is not as good, but with the on-axis illumination you can get a good distinction between the crypt and the thickness of the iris. So you don't need on-axis illumination for everything. So when you do a posterior capsulotomy, you do perform a posterior capsulotomy with off-axis illumination. But if you want to treat the vitreous, if you want to treat floaters, you need on-axis illumination. And by on-axis, I mean I explained the differences between the ones in the market. So by on-axis, I mean the one that you get a focal point inside the vitreous, so you get a very good visualization of the floater itself, instead of getting a better red reflex, instead of getting only a good red reflex. So this is the difference once again. So you get the two prisms, and you get the focal point inside the vitreous, less red reflex. But as I said, you don't need a very, very bright red reflex for that. So you need a good visualization of the vitreous. This is what you want to treat. And if you do compare the two machines that are actually out in the market for treating floaters, you can see that apart from being able to treat floaters and visualize the treatment, because as I said in the LX, you have a drop down of the mirror. So just for a fraction of the second, you don't see what's happening. The other very important thing is that you can do SLT with a Lumenis Duet with both on-axis and off-axis illumination. So in my practice, I cannot imagine having to do SLT with off-axis illumination, and I don't find a reason for that. Because when you're doing SLT, you don't have to focus the aiming beam. What you have to focus is actually the beam of the light in the trabecular measure. So you need to get a good visualization of the trabecular measure. The aiming beam is always coaxial, so you'll get the energy you want at the point you're seeing, but you want to be able to get a good visualization of the trabecular measure. Apart from that, you can see that the Duet comes with a flanking post table, which is very comfortable for a wheelchair. I must say that it doesn't have that anterior offset that the LX has, but I've never found myself being in need to use an anterior offset in my YAG laser or any other YAG laser. Even if you want to, let's say that you had a complication and you have some in your cataract surgery, you had a vitreous strand coming in the wound, and you have to treat that. I just set the offset to 0, and it's very, very easy. I've never found the need to use an anterior offset for my YAG laser treatments. So starting to do vitreolysis, the best thing to do is actually get a good candidate for that. So we don't need to treat everyone that has a floater. We treat people that do have symptoms that affect their quality of life. The floater has to be there for quite a while. So if you get active floaters or flashes, then you do check the patient for a possible RD or a retinal hole or tear. This is not a good candidate. You have to wait a while for everything to be stable to treat the patient. We treat floaters that obstruct the field of view. The floater must be within the safe zone, at least 3 millimeters away from the lens and 3 millimeters away from the retina. The best floater to treat is a vice ring. The patient must not, as I said, report any flashing lights. They shouldn't have a condition that prevents focusing like a cataract or a corneal disease. And and you actually have to explain to the patient that you may not be able to treat every single floater that they have, because there might be some small strands, but the bigger one and the more central ones are the best ones to treat, and the ones that do change the quality of life for the patient. So in general, as I said, a good candidate. You need to use a proper power for the proper energy. So you need to be above the optical breakdown point. The deeper you go inside the vitreous, the more energy you need to use to treat the condition. For the smaller floaters, you need less energy, less shots. But for the larger floaters, you need more shots. And the more experience you get in that treatment, the more shots you're able to use without fearing without the fear for retinal detachment. And another thing to take into consideration is that it's better to be within the safe zone, at least 3 millimeters away from the retina and 3 millimeters away from the lens. When you fire the laser and you hit the floater, most of the times it's used posteriorly, and you have to instruct the patient just to look slightly down and then back to you, and the floater just gets back in place. And you have to also be careful of the cavitation bubbles at the time you're vaporizing the floater. So these are Dr. Hood's general recommendations for floater treatment. So when you focus to treat the floater and you can't see the retina in focus, just don't fire the laser. You need to be just in front of the retina, not to be able to clearly see the retina. In the beginning, you start with 5-6 millijoules and 1 pulse per burst. I don't use any more than 1 pulse per burst, to be honest. And a good place to start is to start with a pseudophakic patient that complains for floaters, and it's much easier to visualize a floater and be able to treat it. So taking into account and into consideration everything that I have discussed previously, you can see with the Duet, you are able to have on-axis and off-axis illumination in both SLT and YAG treatments. It is something that you can upgrade. You can add a photocoagulator or a sub-threshold laser to that. we shouldn't forget that Lumenis is the inventor of SLT. This was the first and the original SLT ever designed. There are many studies. Most of the studies that I mentioned before were done with a Lumenis SLT laser. This is one of the biggest, one of the largest installed base in the US. You do have that wheelchair accessible table, and a very important thing is that you have a low optical breakdown, because as I mentioned before, to treat floaters you need to be above the optical breakdown. So the lower the optical breakdown, the less energy you need to treat the floater. So I do believe that with that system that I use as in my everyday practice, you can get the best of every world. And you can get on-axis, and the most important thing is that you can get on-axis and off-axis illumination just by tilting the illumination tower. So you can get that just in a fraction of a second. You don't need something new to set up. You can have off-axis and on-axis illumination even before you start every treatment. Thank you. So I will be happy to answer any questions that the audience may have.
Does anybody have any questions at all? Is it possible to have the presentation, Dr. Bazinas? We have a question coming through. Is it possible for that to be shared with the group?
Yeah, sure, it's fine with me.
Okay. Thank you.
It's fine. You can ask either Mark or Simon. I will send them the presentation and they can email it to you.
Great, thank you. Okay, guys, it doesn't look like we have any more questions. So with that, we say a big thank you to you, Dr. Bazinas, for your time this afternoon. And if you can send those slides over, I will share it with our participants today. So thanks very much, guys, and have a great afternoon.
All right. Thank you very much. Bye.
Thank you.